So what are some nursing considerations in patients with hip replacement? We want to monitor their vital signs, especially post-operatively. We want to make sure that they are not spiking a fever. Although about 24 hours after surgery, it's not unusual for a patient to spike a low-grade fever. This can be treated with Tylenol. When the fever goes above probably 100.4, it may be time to give the physician a call and let them know. We want to monitor their intake and output. We want to make sure that they're doing some deep breathing and some coughing and some incentive spirometer use and pain control. Many patients in the hospital have what we refer to as PCA, or patient-controlled analgesia, where they actually push the button when they need a dose of pain medication. The button gets pushed and a dose of morphine or Dilaudid is delivered to the patient for pain control. Another important nursing assessment for a patient status post-hip replacement is to assess the extremity for circulation. So that includes capillary refill and checking pulses, also checking movement. Can the patient wiggle their toes? Can they move their foot? And sensation. So can they feel? Is there any numbness? Is there any tingling? These are things that we assess the patient for as the nurse to make sure that there are no complications resulting from their hip surgery. We also want to assess the extremity for color and temperature. Again, cap refill, distal pulses. We want to be checking for edema, and we also want to be checking for pain. And when of course they're going to have pain. That would be natural. However, if you have a patient that is status post-hip replacement, we expect the pain to be in the hip. So, for example, if they're having pain in their lower calf, then that may be an indication that they're having a deep vein thrombosis. So this is something that we would run a report to the physician. The other thing that's important to report is pain that is unrelieved with the use of pain medications. Okay, so let's take a few minutes to do a care plan on a patient who's status post-ORIF of the left hip, and what this shorthand on the top means on the bottom: status post-open reduction internal fixation of the left hip. So our nursing diagnosis for this patient might be impaired physical mobility related to pain, as evidenced by the patient refuses to change position. He rates his pain at a 9 on a 0 to 10 scale, and he states, "No, I will not get up when those physical therapy people come to see me." Okay? So in our 3-part nursing diagnosis, we can see what our problem is, our impaired physical mobility, what it's related to, and what our evidence is that this is a problem for the patient. So what are we going to assess or notice being the nurse for this patient? Well, it's going to be important for us to do a very thorough head-to-toe skin assessment. We want to make sure that there is no skin breakdown because, again, these folks are laying in bed quite a bit, and they're not getting up and moving around a whole lot. We want to assess their nutritional status. We want to make sure that as soon as they can be eating regular meals again, that they are, and that they're getting enough protein. We want to promote wound healing. We want to know what their pain level is, and if they're refusing to participate in ADLs, like this gentleman was refusing to get up, we want to figure out what the reason is. And if the reason is pain, then we need to do a better job controlling that patient's pain. So some of the interventions or responses that we can do for this patient are to administer morphine as ordered for breakthrough pain and prior to physical therapy. So perhaps if we get this gentleman some medication on board before the physical therapist comes to do the therapy, he will be more agreeable to getting his therapy. We want to teach proper use of the PCA. So for example, PCA can have different settings. So there can be a demand dose, and that means that the patient gets 1 milligram of morphine when he pushes the button, and that's called a demand dose. There's usually a lockout interval on that of about 10 minutes, and that means that he will not get another dose of pain medication even if he pushes the button until 10 minutes goes by. So he could push the button over and over again, and until 10 minutes is up, he will not get another dose of morphine. The other setting that we can have on a PCA is that of a basal rate. And what a basal rate is, or a continuous rate, means that every hour about 1 milligram is going to go into the patient's IV around the clock. So every hour the patient will get a basal of 1 milligram of morphine. And then he may also have a demand dose when he pushes the button of another milligram. Okay? And so we want to encourage food and fluid intake. We would like to log roll the patient every 2 hours and as needed. And we want to have meticulous skin care so that we do not have any skin breakdown. Log rolling the patient every 2 hours the point of that really is to change their position in the bed so they are not laying on their coccyx area, a bony prominence, which has a high risk for skin breakdown. So our goals for this patient may be to sit up at the side of the bed and stand with a walker using toe touch weight bearing on the affected leg. And this all depends, of course, on what our orders are, with the assistance of the physical therapist with minimal discomfort. So maybe our goal is for him to be able to get up using the walker with PT and rates his pain at a 4 or below. We want one of our other goals to log roll him from side to side every 2 hours. We want to maybe have a goal be that he consumes 100% of his meals. Maybe we want another goal to be for this patient to drink 700 mLs of fluid from 7 a.m. to 1300 while we are in the hospital caring for them. And another excellent goal for a patient with impaired mobility is that their skin will remain fully intact from head to toe by 1 o'clock. So the ways that we can assure this are by giving good bed baths, good skin care, get them up moving around as much as we can. And it's important to note that skin breakdown can occur very quickly. So, you know, in a matter of hours, the patient could have a reddened area, could become open, and these are things that we want to prevent as much as possible. So then for the evaluation and reflection piece, we want to say, were our goals achieved? Did our patient drink fluids? Did our patient eat their meals? Did our patient get up with PT and have a comfortable pain rating? Did our patient have no skin breakdown during our shift? Those are all goals that we hope we can evaluate and say, yes, we have achieved these goals. So now we're going to switch gears a little bit and talk about osteomyelitis, which is defined as acute or chronic infection of a bone. So a microorganism enters the blood and gets into the bone and causes an infection. And this can be due to trauma. It can be due to a primary infection that spreads after an open fracture where the bone has broken through the skin and been exposed to the outside. And bone infections can be very difficult to treat because, again, the blood supply to the bones is scant. It's not as strong and well supplied as the organs of our body, okay? Our heart and our liver and our GI tract all have great blood supply, our kidneys, but our bones do not. And so osteomyelitis, bone infection, usually requires about 6 weeks of IV antibiotics, in which case this patient will come in on an outpatient basis. They will probably be on a stronger antibiotic like vancomycin, And they will probably require a PICC line to be inserted so that we can re-access the site and give some of those heavy-duty antibiotics as well. So osteomyelitis can cause death of the bone tissue, and this is referred to as necrosis. And we've all learned many times that necrosis is not reversible. So once there is death of tissue, we cannot reverse this. And so here we see an example of a bone infection in the metatarsal bone of the foot. And a close-up depicts the metatarsal phalangeal joint. And we can see that not only is the infection in the bone, but it's also in some of the surrounding tissues around the bone. So what are some risk factors for osteomyelitis? Diabetes is definitely a risk factor. Renal failure with hemodialysis. Patients that are immunocompromised are at a higher risk. And really anyone that has any kind of insufficiency of blood flow to begin with is going to be at higher risk for osteomyelitis. Intravenous drug use puts those at a higher risk, and our elderly patients are also at an increased risk for developing osteomyelitis. Those who have had a splenectomy are at an increased risk for osteomyelitis as well. And not only for osteomyelitis, but they're at risk for other infections as well, because the spleen actually filters bacteria from our blood. Okay, so there's another risk factor for you. So what can we do to help these folks? Treatment is to drain the open wound, or if an abscess has formed, via a needle aspiration, and this is defined as a needle being inserted into the infected area and fluid is withdrawn. This fluid can be withdrawn for culturing to see what microbe is that's causing the infection. Again, I mentioned intravenous antibiotic treatment for up to 6 weeks. There is also a possibility that a surgical procedure will be necessary. Chronic bone infections that we cannot heal with antibiotic IV therapy are treated through open surgical procedures during which the infected or necrotic bone is actually scraped out.